In terms of the relapse for multiple myeloma patients, essentially all patients relapse from their initial therapy. There is, we think, maybe 10 to 20% of people that 10 years down the line remain in complete remission and there's no evidence of progression. And those are the lucky few, but essentially all those patients will eventually relapse. If we try to break down, when patients relapse, the high-risk patients are the ones that are going to relapse first. And if we look at just data for patients who have really high-risk disease, like those that have the 17p abnormality, or maybe even patients with plasma cell leukemia, those patients are usually going to relapse within 18 to 24 months. If we look at patients that have undergone a single autologous transplant and lenalidomide maintenance, then the remission duration is more like 50 months. Primary therapy outside of an autologous transplant, like in the SWOG study, the progression-free survival is around 40 months. I use those as really goals for patients to achieve that tells me, do they have good myeloma? Do they have just standard run-of-the-mill myeloma? Or is their myeloma now high risk? Did they really relapse earlier than what we expect? And those are kind of the ways I follow people and kind of assess their response and how well they're doing to primary therapy. We know that at relapse, the myeloma biology changes. It changes in ways that if we look at their mutation status, from newly diagnosed to first relapse to second relapse, we know that with each relapse, they are gaining more and more mutations. And this is probably some genomic instability. And we also know that there are clonal differences, and that for each regimen that a patient gets, what comes back is a more resistant clone. It could be resistant just to the regimen you just gave them, or it might be resistant to all the regimens, depending on how fast they've gone through their various therapies. But certainly, the clone that is coming back after each relapse is becoming tougher and tougher and tougher to treat.
When we have a patient who's experiencing a relapse post-stem cell transplant, whether they have been on maintenance or not, the reality is we have a plethora of options for those patients. If one goes to the NCCN guidelines, you will see that there's a number of options, but primarily what we're thinking are combinations with carfilzomib, or carfilzomib as monotherapy, daratumumab combinations, or other combinations that could include elotuzumab or ixazomib, all of which have been proven through phase 3 clinical trials to be beneficial for patients. Now, in reality, when we look at our patients, unless one is dealing with a very indolent relapse, the majority of patients are going to go through a combination that contains carfilzomib or carfilzomib monotherapy, or a combination with daratumumab, particularly daratumumab plus IMiDs. Now, there's other subsets of patients that may benefit from one of the other combinations. For instance, patients with high-risk markers or patients who live far away from a treatment center can do very, very well with ixazomib. In fact, we use that as one of the regimens for maintenance post-stem cell transplant. But I would say most of the time we're having a conversation with patients between a carfilzomib-based combination and a daratumumab-based combination, both of which have the highest level of evidence that's provided by the NCCN guidelines.
At relapse, clearly patients are no longer responding to the treatment and their disease has come back. And the question is, what is the nature of that relapse? Because not all relapses were created equally. There are some patients that have explosive disease, for which you may want to select one type of treatment. There are patients that have a slow, indolent relapse that you may want to watch or use a different type of more gentle treatment. And this is all governed by the genetics of the cancer, but also by the duration of time patients had off treatment and the treatment that was used up front. So when you're selecting a regimen for people at relapse, you have to consider the nature of the relapse, their disease-free period, what they were treated with up front, and what side effects they've got. And then by considering all of those factors, it becomes much easier to select a regimen. There's a number of regimens that have different modes of action. So the monoclonal antibodies target the immune system to the surface of the myeloma cell. This is a relatively novel mechanism, and so you're taking advantage of the immune system. The IMiD drugs target Icarus and Aiolos to the proteasome for degradation, so they target the myeloma cells directly and increase the immune effect. Proteasome inhibitors are very important and target the proteasome and inhibit the cell cycle, stress the endoplasmic reticulum, and affect NF-kappa B signaling. The histone deacetylase inhibitors are anything but histone deacetylase inhibitors, and it's probably better to consider them as just deacetylase inhibitors and what they do to the proteins in the cell, so they can target the epigenetic status of the cell as well as targeting HSP90 and a variety of proteins in the cell. So using those, you also need to, so those are their modes of action, you need to know their side effect profile. So if you've had a thrombosis, it's more difficult to use an IMiD. If you've had peripheral neuropathy, using Velcade is difficult, and you should choose a proteasome inhibitor that doesn't have a neurotoxicity portfolio. The HDAC inhibitors make you anorexic and make it difficult to give other drugs, so they're difficult to use in combinations. The monoclonal antibodies have the least side effect profile and combine well with IMiDs and or proteasome inhibitors.